Hello everyone, welcome to the second episode of MSK Unlocked. Today we are going to discuss about knee pain. We're joined again by our FCP specialists, Chioma and Ashri. Thanks for being here again.
Thank you for having me again.
Thank you.
Lovely. Can you guys tell us a little bit about your current roles and your backgrounds?
Yeah, you're gone.
I'm Chioma. I work as a first contact physiotherapist and I have a background of working long-term in community physiotherapy and other aspects of physiotherapy.
So I'm Ashri. I work as an advanced practitioner physiotherapist, and I also work in primary care as a lead first contact physiotherapy supervisor from past few years, and my area of interest is rheumatology and joint injections.
Lovely. Let's talk a little bit about what we think are the common causes of knee pain.
Yes, when it comes to knee pain, I think the common causes would include overuse injuries,
Okay, yeah.
arthritis, and quite a number of them. When you're talking about overuse injuries, the most common presentations of that would be tendinitis,
Okay.
and it's quite different in presentation.
Mm-hmm.
You know, when they present with knee pain, and then you try to determine what exactly caused the pain and know how to help it. From the history, the presentation, the questions you ask, the lifestyle and all that, it's a bit easy to pinpoint what exactly is the cause of the knee pain they're coming with.
Yeah.
I think mechanically, what we discussed earlier was body weight is one of the things that causes mechanical. I think that's where we do patient education.
Yeah, I would think that.
Healthy body weight.
Yeah, I think that body weight per se, I wouldn't really put it as a cause. I'll put it as a risk factor,
Yeah.
and as something that worsens knee pain.
Well, yeah. I mean, when we are talking about body weight, specifically knee, because it's, again, I'm quoting from the book, every increase in 1 kg of the body weight can increase the amount of load by double. So that's more, it's well documented that specifically when it comes to knee, the body weight has a big factor. So I personally feel body weight is one of the major factors when patient develop anterior knee pain or osteoarthritis or even inflammatory joint disease.
Tendinitis, hyperextended knees, weakness.
I think exactly, yes, flat feet also is a factor, but for me, on the thing, because I believe lifestyle plays a major role, I'm thinking about the kind of shoes they wear, the kind of work they do. Are they runners? The kind of where they live in, do they use mainly even surfaces, or are their walking surfaces mainly uneven? That's why you're looking at iliotibial tract syndrome, and
if they are retail workers and security workers.
Exactly, the kind of work they do. Are they standing for long? Are they sitting for long? Do they?
Again, I completely agree, but I've seen the most active people, but coming from a certain ethnicity, like for example, flat feet, anterior pelvic tilt is common in Asian and Africans, and then in that case they've got more valgus knee. So more of biomechanics. When we look at biomechanical nature of knee pain, that has got a lot to do with the posture, ethnicity, and also the weight as well.
Yes.
Let's move on. Talk about red flags in knees. What sort of presentations we see?
So, I mean, again, knee red flags is not something that we commonly come across, but this is why it's really tricky to actually identify. One of the major risk factor or red flags is any inflammatory knee, septic arthritis. I had a patient last week. The patient is hemophilic. He has beta 2 hemophilia. So what happens in hemophilia is they tend to get this bleeding around joints and knee is the commonmost joint where you tend to have that bleeding into the joint. So again, that may present to us is the same way as acute bursitis or tendinitis, but so history is quite important. If the patient is already telling you that you have a history of hemophilia or sickle cell disease, and suddenly the knee pops up, the swelling is quite intense, and you have warmth and fever. So that's like obviously a red flag when somebody has fever or knee ballooned up twice the size of the other side, and also it's redness and warmth. So again, because these are not very common in primary care, it's very difficult to assess those things.
It's quite important, especially with septic arthritis, for us to screen these patients, or GPs to screen these patients and direct them in time to A&E. Otherwise, obviously, sepsis, and they can have bigger issues.
Same thing post injections as well. Like when we do joint injections, one of the main things that we educate the patient about the possibility of infection. If somebody developed a swelling, not just within the 24 to 48 hours, even after 3-4 days, red hot swollen joint, we have to
correct them. Another thing is also we see locking or unstable knees, complete ACL tears, meniscus tears. How would we manage that?
So there's a difference between emergency, like somebody when we are sending a patient to A&E versus urgent referral. Okay. So when we discuss about acute locking of the knee, acute ACL tear or meniscal, so you obviously have to safety net if the patient goes to A&E, but that's more like a urgent referral versus the emergency.
So you're saying it's not a red flag, but it's just something that has to be managed. Probably is a route.
2 weeks part.
That's fine. Let's talk about how physiotherapy exercises and maintaining a healthy body weight can help. And I think we already sort of discussed a little bit more about it, but how can exercising help knee pain?
Definitely exercises can really help knee pain, especially because certain exercises help with improving the range of motion, and with improved range of motion you have more function. Exercises also will help, you have the stretching exercises, the strengthening exercises. If, for example, in a patient that has an extension lag, where the patient is not able to fully straighten the knee, to give the patient exercises, stretching exercises that help to stretch the knee flexors, and so that this patient does to help stretch the muscles that help bend the knee, so that this patient can straighten further, straighten the knee better and move better. First of all, you've helped to correct the alignment and encourage proper biomechanics on that knee, because imagine having to walk on a bent knee constantly. You're going to be increasing the wear and tear on certain portions of the knee, especially the anterior, that's the front part of the knee. And then if you're able to give exercises that help the range of motion, so all these are better. Exercises also help with strengthening. Now, if the structures that support the knee, I usually describe it to my patients saying, you've got these tendons, ligaments, and if all the structures were strong enough, they act as harnesses to this is the knee, you strengthen everything, it holds things in place, so you don't have unanatomical movements just occurring all over the place because it's stopped and in place. So, it keeps the knee moving just within the normal anatomical range, okay? So if the structures are strong enough, you're able to reduce unnecessary movement and therefore unnecessary wear and tear. And of course, with unnecessary wear and tear, you have less progression of the condition you have. So definitely, and I know this might not be so quite widespread, but I also believe that these exercises you give help to encourage local circulation at the knee, because you're increasing local muscle pump activities. When muscles contract and relax, muscle pump activity. And with increased circulation, you have less likelihood of pain-causing metabolites congregating at a region. So with increased circulation, you don't have pain-causing metabolites in a region. So if it's flushed away, this patient is going to have less pain. And with less pain comes what? More function. The patient feels more alive and more able to do things he loves doing. So honestly, from knee pain, you've probably even solved other social problems for the patients,
I think as we discussed in the previous one, that exercise is medicine. I think that's the mantra for all the, except for when we suspect septic arthritis, and obviously exercise is contraindicated. But apart from that, in every other scenario, we can safely prescribe exercises.
I think one of the things I do tell my patients with arthritis is, they say, can this be treated, osteoarthritis? And we have to tell them that this is just how the joint changes as we age. So this is degenerative change. They're not very pleased to know that this is irreversible. They look at it as a disease, and I said this is not a disease. The joint is like a machine and it wears and tears over time. I do tell them the effect exercises have in sort of dealing the progression of arthritis as well. If you are sedentary, if you don't exercise, the disease, osteoarthritis, is going to progress faster. The cartilage degeneration is going to be faster versus you don't do anything about it. So I say synovial fluid moves when you exercise, and that sort of keeps your remaining cartilage healthy, and that kind of helps make sure you're not in a severe arthritis where you probably need a joint replacement. Let's talk about steroid injections, a hot topic. At what point do you guys in your clinical practice refer patients for steroid injections?
So I think obviously there are guidelines, but in the actual clinical scenario, it varies from patient to patient, from condition to condition. So it's really important, first of all, to understand that these injections are only for temporary measure. It's not going to cure the problem, but it's kind of giving the window period where patient can do those exercises and can get better. One of the common, I think in primary care, the commonest injection that we do is knee and shoulders.
Yeah.
Because with the knee, again, because it's a heavily weight-bearing joint, whenever in common presentation, So if we categorize, now I'm talking about the elderly, where arthritic knee. So we have our mild, moderate and severe osteoarthritis, knee osteoarthritis. The evidence are not great for severe osteoarthritis. If we do joint injections in severe osteoarthritis, the evidences are not good. It works kind of better in moderate arthritis. But I feel that the pure criteria to refer someone for injection is the pain level, the activity level. If somebody who has already tried these self-help exercises, they are on medication, non-steroidals, or there is a contraindication for them to take non-steroidals, and yet they are not improved and they have got swelling, they have got pain, in that case, there's a big role of steroid injections, because steroid, as the name suggests, it just calms the inflammation down. It gives that window period. But it's also important to realize that we don't just consider the radiological changes. So there are instances where the patient has severe osteoarthritis, but they don't want to go down the surgical route, or the pain has recent flare-up. Injection does have good evidence on that. And usually 40 mg with steroid, decametron with lidocaine, that's the standard what we prefer. But again, even with steroid injections, you have to, if somebody is moderately obese, they are overweight, or they have any uncontrolled diabetes, sugar level.
Have good outcomes.
We can't. The injections are completely out of question. So I think it's on individual requirement. And the other day I had a patient with recently diagnosed lymphoma. So he recently finished his chemotherapy treatment, and there was plastic anemia. So there are certain conditions where, again, that's a big topic, do's and don'ts or contraindications. But from my personal experience, I have noticed injection working wonders.
Really well,
It works really well, especially when the patient are really struggling because of the pain. But what I wanted to emphasize here is, if somebody has already done physiotherapy for let's say 6 to 7 weeks, and now not necessarily that they need injections, it's important for us to also check whether they have tried non-steroidals as well. If they have tried ibuprofen, naproxen, or a strong opioid like cocodamol. I feel jumping to having the steroid without trying these again could be
not good practice.
But again, if somebody has gastrointestinal issue, they've got kidney disease, they can't have, then in that case steroid is a drug of choice.
What do you guys think are the myths around injections with patients? So a lot of patients will come into my clinic and they will say, my friend or a relative had an injection and it helped them, or some of them are like, one of my friend tried the injection and it didn't help them, it made their symptoms worse, I don't want it. So they have these perceptions about the injection even before discussing with us that it works or not, just based on a relative's experience. What do you guys think?
Yeah, it does exist. There are definitely a lot of people that feel, they need this injection. So no matter what you're saying, through other consultation, you're just
nothing about research. They just think,
my friend had this injection,
it's not going to work for me.
It helped the pain, and my friend is fine now, so can you just give me injections? And some that are very nice, they will just let you speak, and when you've exhausted yourself, can I please have the injections? And I mean, it's a road that we really need to look into. Personally, I try to tell them that it's in their best interest to try having these exercises first, because like she said, the injections are not solving the problem. In fact, basically, they're helping the inflammation and they're helping you to not feel the pain. It's not taking away the problem. And do you know what could happen from that? Now, because, I always tell people one thing, pain is not exactly the bad guy, Pain is protective. It's there to let you know, hey, stop, And then, take away the guy guarding the gates. And then you go take something, now you don't feel anything no more. hello honey, you're going to feel like you're Superman.
Yeah.
And you're going to go into those risky behaviors that caused the problem in the first place, or even worsen them. And guess what? When the effect of the injection wears out, you are not just back to square one, you're back to square 0 points.
Yeah.
Square minus points too. Exactly. So I think it's important to let people understand that that exercises really help, and injections help, but for me it's a seesaw. In fact, generally when it comes to pain management, well, according to me, I often feel that patients should go more for the exercises, except in situations where this pain limits the compliance to the exercises, limits their daily function and quality of life. Because now you're not just considering the pain the patient came in with, you're also considering other aspects of the patient's life, like the socio-economic and other parts of the patient. If this patient, because of pain, cannot do the exercises, of course you're not even getting any headway with the patient. If this patient, because of pain, cannot go to work and do the things he loves, depression is at the door knocking. If this patient, because of pain, is not able to go to work, that patient ends up broke,
I think it also condition specific. Like we talked about the myth. One of the common myth I have come across is steroid injection. I'll put on weight. That's the commonest thing I've come across. I'm not gonna take steroids. I'll put on weight. I don't look fat. So it's important to tell them that this is not anabolic steroid. It is a joint-specific steroid injection which purely aims to decrease your inflammation. The other, we were talking about the arthritic kind of scenario. It's important to also realize patients have patella tendinitis or bursitis. They all have intense swelling as well. And the evidences for injection, the role of injection is any tendon pathology like tendinopathy is quite less because of obvious reasons. But again, at the same time, having said that, I have injected people who have got bursitis or tendinitis purely because of the pain and the inflammation swelling around this thing. Obviously, things are different when we have Baker's cyst because majority of the time it just dissolves on its own. But leave it alone. Leave it alone. And also because of the wait time in NHS, to see, because with Baker's cyst it has to be aspiration or injection under guidance, and not everybody is trained to do guided injection in NHS. So by the time they reach, usually it dissipates. If not, then
And I think another important point about injections is to set patient expectation as well, because they think that this is an injection which is going to get rid of their arthritis or get rid of their pain forever, that this is some magic injection that they're going to inject in the joint. So I think one of the patient education, that's our responsibility to tell them, this is just to manage your symptoms. This is not going to solve any problems mechanically in the joint.
Just here, Ekta, I wanted to add, a lot of time I've been asked that, I had one injection, it didn't work. How many I can take this one year? So, we can, the fact that the first injection did not work, the chances of the second working is reduced now. And same applies to a patient who have never had steroid injection. They ask, this is a common question that patient asks, is it one-off injection? How often do I have to repeat? So yes, this is a one-off injection, and if you've never had the injection before, you're going to take the first injection, the chances of that injection working is lot better than when they have subsequent. So yes, in reality, they can have multiple injection, 3 injection in 1 year time, but we as a clinician, we have to discourage that.
Sometimes I come across some orthopedic specialists and the patients have had maybe 6 injections a year, and I say, how is that right to do? Because the long-term effects steroid injections have on the integrity of the joint, how it affects cartilage long-term. So that downside is something that patient is not probably informed by these specialists at that time, and they keep having repetitive injections just because they don't know, so there's misinformation as well.
And because it actually represents an easy way out.
Exactly. I don't want to do exercises. Let me get an injection.
That's it. I think it depends on the condition as well. Somebody who has been having inflammatory joint disease, rheumatoid arthritis for years and years, they tend to have repeated injection because of the obvious need. With mechanical, I feel the onus is on us. the orthopedic surgeons, the specialist registrar, they are far too busy to. So I feel this is us. We are the people who should be guiding us in this.
Let's move on to when is it safe to have an injection. So when we screen patients for steroid injections, what are the key things that we look into? So probably the medical history side of things, and is there any medication that's contraindicated? What do you guys think?
Yeah, so when we are, I'm purely talking about non-prescribing injectors, because we have to abide by the local PGD, and the PGDs are slightly different in different areas. Say for instance in Barnet, in some hospitals, under the PGD, we cannot inject if someone is on blood thinners, like like a lot of warfarin and that kind of thing. Well, again, warfarin, a lot of the NOACs and DOACs, you guys might have heard about DOAC and NOAC, the newer version of the blood thinners. So the newer version, like clopidogrel or any kind of DOAC, are relatively safe. They don't have to stop the blood thinners before having the injections. But with warfarin, obviously, it's important that we monitor their INR level and whatnot. But in some practice, in some trust, it's a complete exclusion. If patient is on blood thinners, we cannot do injection. Whereas when I was working in Croydon Hospital, everything is included, because that's more like a medical setup. There are more medical people to guide you. So it differs from place to place. But as clinicians, we know the absolute contraindications. And few other things like patient on anti-epileptic, like lamotrigine, that's one of the exclusions in the Barnet area as well. So it's important that we follow the specific PGD of that trust. But there are some conditions which makes it quite generalized, like contraindications. So that's, I think, as a primary care clinician, it's important for us to know about that. Because that's something that we cannot go wrong of. I mean, we can't be, injecting steroid and lidocaine with a patient who had a history of anaphylactic reaction to anesthesia or of any of kind. So history is quite important. If I had a patient a couple of months ago, she had a repeated history of anaphylaxis from penicillin, because penicillin, beta-lactam antibiotic, one of the prudent beta-lactam antibiotic, penicillin, which has a documented history of anaphylaxis or allergies. That's the antibiotic most of the people are allergic to. The interesting thing is the patient said about that history, and then actually when you delve deep into it, there was one history where 10 years ago she had an ENT or dental procedure, and she was also allergic to one form of anesthesia. So in which case it's for us to then be cautious about and just give steroid, not add lidocaine. So I think there are certain things that we cannot go wrong with. We can't afford to.
True. I think just to add on what Ashri said as well is if they've got uncontrolled diabetes as well, so patients, if they already know they have type 2 diabetes, if their diabetes is not well controlled, we can't inject these patients. Also, if they've got any sort of kidney conditions, if they've got any liver conditions as well, so any sort of systemic conditions, kind of not very safe to inject. Infection, yes. Any sort of allergies, if they're allergic to the drug as well, we wouldn't inject them. Any sort of traumas, fractures.
I think with the diabetes, because this is a question that I get asked the most. When we say uncontrolled diabetes, that value we consider HbA1c value, because that gives you 3 months. So HbA1c is different for you. It's different for someone who's already is diabetic for many years. So when we say uncontrolled diabetes, we refer to their normal sugar level. So somebody who's let's say patient A who has diabetes for like God knows 20 years, they're on metformin, they're on sitagliptin, and their usually normal blood is 6.6, and suddenly they have 7, then in that case that's contraindicated. But if they have 6.8, even though technically it's a lot
high,
but we can still inject provided it's in control. And the same thing with kidney disease as well. Somebody who has chronic kidney disease, there are stages, stage 1, 2, 3, 4. So it's quite important to say the recent blood result. If there are sudden changes in the recent blood result, when I say recent, it will be in the last 3 months or 6 months. If suddenly there's a rise in their creatine kinase or their glomerular filtration rate. The GFR is the most common, the single most important determinant of chronic kidney disease. So if there is a sudden drop in the GFR in the last 3 months, that's a contraindication. But in general, if somebody has a chronic kidney disease stage 4 or 5, then
That's moving on.
or you discuss with the GP or the medical professional. You cannot just go blind and inject.
Talk about how can patients access steroid injections. So is this something that GPs can do? Is this something physios or FCPs can do? Or is this always a secondary referral? What do you guys think? So just to let patients know.
Definitely it can be done at the primary care level.
Yeah, good.
We have lots of FCPs that do injections, and some GPs do injections too. Not all do. And so I think at the primary care level it should be just the normal way. It's best they go through the approach.
So they don't have to wait for months.
They don't have to wait for months on end to get the needed injections.
I think again it's important to understand the limitations of, yes, we all can do joint injections, but every profession has a limitation. We have a limitation. Let's say I'm injecting the knee joint, I cannot go more than 40 mg with the steroid dose. So I think with all professions, advanced practice nurses, physiotherapists, pharmacists, it's important to know what we can do, what we cannot do in our premises.
And I think that is all for the knee podcast. Thanks so much again, guys, for coming. This was very informative. If you guys thought it was helpful, please subscribe and share. Thank you. Thanks, guys.
Thank you.
Thanks. Bye-bye.